Good morning, everybody. Good morning, sir. Today I'm Dr. Deep Vohra and I'm assistant professor at Tata Memorial Hospital, Parel. And today I'm going to talk about supportive care in geriatric lung cancer patients. Is it important? So we know that almost 40 to 60% of our lung cancer patients are around the age of 65, and almost 30% patients are above the age of 70 years. So yes, it is a good number of patients that we have in elderly age group in lung cancer. What we know is that in most of the trials of phase 2, phase 3 trials of lung cancer, less than 25% patients are of this age group that we are looking at right now. So we actually don't know what happens to these patients in detail. So what happens ultimately is we either overtreat our patients or we undertreat our patient. We may give more treatment to patients who may not be able to tolerate it, or we may not give proper treatment to patients thinking that their age is very high and we undertreat those patients. And ultimately, when we treat young patients, we see performance status, ECOG, PS 1, 2, 3, 4. But these are not accurately predictable of outcomes in elderly population. So we need to do something more for these patients. There are unique challenges that one of them I already said, that we don't know. We don't know, and that's why we either undertreat this patient. Historically, almost less than 50% patients do receive any antineoplastic treatment in such age group, which is a very high number. And sometimes we also overtreat such patients and leading to unnecessary side effects, toxicity, sometimes even mortality also. The solution here is we should have more trials. Including such patients, we should have better trial designs as well as implementing strategies for such group of patients. Other thing is, aging is a heterogeneous process. So not all young patients are functional and healthy, and not all older patients are sick and dependent. If we see the first two figures and the last two figures, what do we think? The first person, most probably what we'll think is that the first person should be able to tolerate whatever heavy chemo we want to give, and the second patient most probably should not. Now if we see the age-wise distribution, it's almost same for the first two as well as almost same for the second two. So it's heterogeneous, it's different for different patients, and it's not same. Other thing is, with aging there is impact on different organ systems also. So there will be decline in the functions of kidney, heart, lung, nervous system. And this decline will not be obviously detectable when we are just looking at them and we are doing the blood tests only. But it may be revealed at the time of stress, such as if we give chemotherapy, if they get infections or some other conditions. At that time, this will be more vigilant to us, and then we will end up the end result will be the patient will be having more acute illnesses, more complications during cancer treatment, which ultimately affects the outcomes. Another important point is frailty. Frailty means it is a state of increased vulnerability to stress. While we are able to tolerate stress in a more better way, when we are frail, we have more vulnerability and worse outcomes for such patients when they have stress. And as we know that because of genetic factors as well as environmental factors, there is reduced physiological reserve. So this reserve is already less, but it is not obviously visible at baseline. And when there is some other stressor event or some other physical activity, nutritional deficiency, infections, anything, it leads to something called as either frailty or increased vulnerability to poor outcomes. And this frailty also leads to something called as geriatric syndrome. Geriatric syndrome also has effect on frailty that we see in further slides. So these are a vicious cycle that keeps on going, and patients end up being more vulnerable. So what geriatric syndromes we are talking about? These are basically multifactorial pathophysiological events. So it's not a single event, one UTI leading to some deterioration in outcome. It's a multifactorial event that ultimately lead to some stereotypical clinical presentation. So clinical presentation will be similar for incontinence, for falls, but there will be multiple reasons leading to those kind of events that are happening. It is very highly prevalent in older patients. Almost more than 60% of older patients have at least more than or one geriatric syndromes in our scenario also. These are some of the geriatric syndrome that we are going to discuss now: dementia, depression, delirium, falls, pressure ulcers, failure to thrive, immobility, something like that. So first is mobility impairments. Patients are not able to mobile properly, and we just have to ask. We don't need to do so many things for identifying such impairments. We just need to see how they are walking. If the patient is coming on a wheelchair, just tell them, just walk to the chair, and you will be able to know so many things about the patient, whether the patient is walking normally or not normally. Now, not normal can be walking slower with some gait disability, slower walking, fast steps, leaning forward, taking more time to getting up from the chair or doing their work. We don't need to go into details of each and everything. We may refer patients to such specialist doctors if and when required, but it will tell us about some things that the patients are okay or not okay. If the patient is walking well, sitting well, talking well, you know that patient is able, most likely going to tolerate whatever we are planning to give them. And if it is not, the other way around. So mobility impairment can be managed also. If we know that these are there, we may try to manage them. For example, if patient is having baseline Parkinson's, because of which he is not mobile, he has other difficulties, we can just start medications for the same. The main important two things here that I want to highlight is multidisciplinary discussion, that is physiotherapy as well as occupational therapy. They do help a lot to our patients. They will have, physiotherapy will have improved strength, mitigate the risk of falls. These all will have ultimately a good outcome for our patient, as well as occupational therapy, just a sitting wheelchair or some other things that will help the patient for such impairments. Again, next is functional impairment. This is not mobility, this is not physical impairment, it is functional impairment. So this includes psychological, cognitive and other impairments, which leads to inability to perform activities of daily living or instrumental activities of daily living. Now these instrumental activities are some more advanced, little bit more advanced daily living activities which require some more attention, some more work to do. So basic ADLs will be walking, bathing, doing all his work on his own, toileting and all those things. But for instrumental activities, there are something like as talking to a phone, managing money, all these things do. These are functional things that a person do in his daily activity, daily life, and if they are not normal, that does affect the patient as well as his outcomes. Why it is important? Different cancer as well as different cancer treatment will have different implications on functional impairment. So patient may not be able to do his many of the activities because of such impairments, and ultimately sometimes we will have to stop our treatment also sometimes because of such things. One more important thing is functional impairment may be worse than shorter survival with good quality of life. For many patients, living long with functional impairment will be much more difficult than having a good quality of life or shorter survival. That is what I want to make a point here. Also, functional impairments will increase the vulnerability as well as increase risk of death. So how do we manage these functional impairments? It's not one thing that happens, it's multiple things that ultimately leads to functional impairment. So we need to have a comprehensive geriatric assessment for such patient. We have to treat the treatable causes like medical factors like Parkinson's, arthritis, overactive bladder. Polypharmacy is very important, where we need to reduce some unnecessary medicines. We should give some pain medicines so that patients' functional activities are better. Just giving pain medicines will help them do their work, as well as some environmental factors like putting a rug or if lifts are broken, give them some support. Another thing, again here also, is MDT approach. Use help of your physiotherapist and occupational therapist here also, and that will improve the quality of life of our patients. So now we'll talk about some geriatric syndromes. Another geriatric syndrome, that is fall. Fall is very common. We don't know, but fall is very common. Only 1 out of 10 patients will report their fall to the doctor unless it is being asked. So it needs to be asked whether you are okay, doing okay or not. It can result in injury, it can result in the treatment discontinuation or interruption, and ultimately leading to worse outcomes. The one important thing is this might be modified. There might be modifiable factors which can prevent falls, which should be taken care of. So these are some general non-cancer related factors which lead to increased falls in elderly. And what we can see here is that there are so many things. Low body weight, you can refer the patient to dietitians. Smoking alcohol, we should tell them to stop. Pain medication, incontinence management, just some basic footwear, better footwear will help them do more work. Even comorbidities, if we see COPD treatment, diabetes treatment will have better outcomes and reduced incidence of falls. Visual hearing impairment, we can just give them hearing aid and it will be better. So there are so many things that we can do for such patients which needs to be taken care of. And there will be some cancer related issues also, like peripheral neuropathy from chemotherapy, which will lead to more fall. Fatigue is one important portion here, because of which patient may fall. Reduction in strength and balance, pain again, anemia, dehydration, all these things can lead to fall, but we have to make sure that that does not happen. So how do we do that? We have to, these are some examples. If patient is having low BP, just look for the BP medications, reduce the doses of BP medications. Polypharmacy needs to be avoided, reduce whatever is possible. Dizziness may cause fall, so sometimes just better physiotherapy gets them better. And some incontinence management and other things also. Next point is bone health. Yeah, we usually, if there are bone mets, we usually take good care of bone mets. But we have to make sure that otherwise also osteoporosis is very common in this age group, and we need to make sure that we are treating for that things also. We are not just treating metastasis. So if we talk about just hip fracture, it's only, if we see hip fracture only, if a patient develop hip fracture, there is a 30% chance then patient will die within the next year. This goes to 50% if patient's age is more than 75% years. The 25% patients will be always immobile, and only 20% patients will fully recover to their normal activities. So one fracture also can change patient's life. So osteoporosis, we should know about this. These are general risk factors which we usually know, but sometimes we ignore them. There are some cancer related treatment factors also which can lead to decreased bone density, and we need to take care that we should be able to giving good treatment for that. We need to assess this patient first. So usually in medicine we usually do is FREX score, but in cancer patients this will underestimate the percentages of osteoporosis. So FREX score will not help you because it is not validated in cancer setting and does not take into account the cancer as well as treatment of cancer which we are giving. So we will have to do something more. So what we usually do for investigation, serum calcium, vitamin D supplementation, look for renal function, as well as do a DEXA scan and treat them accordingly. How do we treat them? You don't need to give too much time to explain to patients. Just a flyer or just a pamphlet will do the work. They will know all these things which needs to be done and which not to be done. Other than this, pharmacology comes, so we can give calcium supplementation, vitamin D supplementation, or bisphosphonates. That we usually do. The next is cognitive impairment. So cognitive, if we actually start looking for it, they have seen that almost 50% of patients are in screening positive for some cognitive impairment. Now screening positive does not mean that they are cognitively impaired. It needs to be further assessed that whether there is some cognitive impairment and what kind of impairment is there. There are some screening tools like G8, some other questionnaires, clock drawing test and all, and these are the advanced tests which we can, advanced questionnaires which we use usually to decide which domain is affected by this cognitive impairment. It has different types. It can be delirium, dementia, or mild cognitive impairment. Delirium means patients, this is common, this is basically acute brain failure, either hyperactive or hypoactive, and it leads to increased morbidity and mortality. Again, it is multifactorial. We need to consider all these things. We need to reduce unnecessary medicines. We need to give good pain management to reduce the chances of patient going into delirium. Mild cognitive impairment means these patients are having some cognitive disabilities, but it is not severe enough to cause a daily living function abnormality. but it will later on, or it has increased risk of developing dementia. And dementia means these patients will have actually decreased ability to do daily living activities. So this is usually not sudden, but we usually find it suddenly. That's why it seems that it is more suddenly happening. Another thing is depression. Depression and cancer have bidirectional relationship. Cancer patients will have depression. Depression has increased chances of getting, depression patients have increased chance of getting cancer also. The prevalence of depression is almost 20% in cancer patients, which is usually 5% in general population. Management of depression we know, but important thing here is psychological. You need to take help of psychologists here also. It's not that you only can manage such things. And other things also need to be treated. Malnutrition. Malnutrition prevalence is also almost 40 to 60% in different cancers, which ultimately leads to cachexia and sarcopenia. And it is also multifactorial, as well as multiple causes can lead to malnutrition. What will happen if patient is malnourished? There will be muscle loss, there will be reduced tolerance to chemotherapy, and there will be increased toxicity from chemotherapy. Just 2 minutes more. Yeah. And if we take good care of malnutrition for our patient, they will have good weight gain, they will have decreased interruption of treatment, and they will improve their ultimate outcomes, as well as decreased cost of total therapy. Incontinence needs to be managed. Again, lifestyle modification, pelvic floor exercises, and later on medications comes. If required, here also we should take support from our allied branches. Polypharmacy needs to be reduced. If we see overall, if patient is taking more than one medicine, in almost 80% of patients, there is potential drug-drug interaction going on based on this study. Most of the patients are taking 1 or 2 tablets, but there are 25% patients who are taking more than 5 tablets in a day, which may or may not be required. And if we reduce these drugs, there is reduced toxicity while the patients are being given treatment. So definitely minimize unnecessary medicine, optimize whatever needs to be given, and minimize drug interactions. That is what we need to do. Last is caregiver burden. There is a burden over caregiver. Almost 50% of caregivers do feel that there is increased burden, which is too great. It can be subjective burden, psychological burden, financial burden, as well as others. So take home message, these are very highly prevalent conditions that are happening in our patients, and we sometimes tend to miss them. We have to look for them. Sometimes even just asking can get us too many answers. Comprehensive geriatric assessment needs to be done for all patients who are eligible, and we need to have good treatment for such things, as well as good MDT. Use help from different branches. It will help your patients a lot. Thank you.
Thank you so much, Dr. Deep, for your wonderful presentation. Just one question for you. Just a question that, first of all, what is the percentage of the palliative care and patients in palliative care that you are seeing on a daily basis? And secondly, you had explained so many things like frailty and geriatric syndromes. What is the correlation of whatever you have explained till now with the palliative care that you are talking about?
Palliative care means supportive care, right? Supportive care. So,
what is the correlation between all the syndromes and everything I've said and that?
Yeah, so the thing is almost 40 to 50% of our patients will be metastatic, which will be requiring, where the goal is actually to give good quality of life instead of giving increased number of days in the life. So almost 40 to 50% patients will be like that. Geriatric syndrome, what we have seen is actually much more common in our patients also. Maybe 50 to 60% patients will have some or other geriatric syndrome, which needs to be taken care of. And so it does improve the quality of life for such patients.